Hello friends, I hope you are well wherever you are. I'm Tembekile Kakeshe, the physiotherapist. We are going to continue with our session. Today we are going to take the part of the central nervous system that is the peripheral nervous system, specifically speaking the brachial plexus of the peripheral nervous system. The nervous system is divided into two: the central nervous system and the peripheral nervous system. The central nervous system is the brain and the spinal cord. The peripheral nervous system is all the individual nerves that connects the spinal cord to the periphery of the body. Now we are going to have a look on these pictures from Netter's Atlas. If you can see here, this is a picture of the brachial plexus, and then this one is a picture of the brachial plexus connected to different structures including muscles. This part is the way peripheral nerves originate or join the spinal cord. Is some few muscles that we will have to mention throughout our session as we try to go through the brachial plexus. Since we said the peripheral nervous system is the part that takes the sensory information from the skin, from different parts of the body, into the spinal cord up to the brain, where it will be interpreted, and messages will be sent to activate muscle down the spinal cord and out of the spinal cord to the muscle via the same nerves. So now before we start with the brachial plexus, let's just recap how the peripheral nerves are connected to the spinal cord. And bear in mind, all these videos are designed for all the medical students, physiotherapy students, OT students, dentistry. All other medical students are not suitable for general understanding of any person, but if somebody is interested to listen, it's still fine. But the details of the information included here is meant to help the medical students, chiropractic students, different medical students. Right, when we look at the peripheral nerves, we see that this is the spinal cord. And when we look at the center of the spinal cord, this is the gray matter. Around the gray matter is the white matter. And then if you look at this diagram, you can see that this is the ventral part, or the anterior part, or the part in front. And behind there is the dorsal part. How do we know that this is ventral part and that is dorsal part? We can easily identify that because we can see that there, right at the back, we have what we call the dorsal root ganglion, because we know the nerves from the central from the body to the spinal cord will enter at the back of the spinal cord. So now we can easily identify that this is a dorsal part, this is a dorsal part, this is anterior part. Right. This explanation that I'm going to start with, these parts from here to the spinal cord, these parts are within the vertebral canal, but you will see as we continue. So the dorsal part and the ventral part, these nerves will attach to the spinal cord via what we called filaments. They call them filaments of the ventral root, or ventral root filaments. These one in front, and the one at the back, these filaments are called filaments of dorsal root, or dorsal root filament, and they come together and make one root, which is called the dorsal root of the spinal nerve, and the one in front come together and become one and make one ventral root of the spinal nerve. And the dorsal one is the one that brings information to the spinal cord and up to the brain for interpretation. And these cells, they've got nucleus, and the number of these nucleus that are within this structure are called ganglion. Therefore we call them dorsal root ganglion. So it's dorsal roots is dorsal root filaments, or you can call it rootlets, but let's call it filaments. Dorsal root ganglion, in front filaments, ventral root, and then they both combine to make the spinal nerve. The spinal nerve is actually the part that you will see coming from the intervertebral foramen of the vertebra, of the vertebral column. Then immediately, as we say, this what we call the spinal nerve is the small part, is the part from here till here. The spinal nerve starts here by the combination of the dorsal root and ventral root to make the spinal nerve, and then they come together to make the spinal nerve, of which the spinal nerve is very short, it's less than 1 centimeter. That is the spinal nerve. So it will immediately separate into dorsal ramus and ventral ramus. This part of the dorsal ramus will not be the part of the brachial plexus or cervical plexus or lumbar plexus or sacral plexus. The dorsal ramus is not part of the plexus. Is this part that will break again to separate muscle of the back. This part is not part. So the ventral ramus is the part that will become the root of the brachial plexus. So what is the root of the brachial plexus? The root of the brachial plexus is actually what we called the ventral ramus of the spinal nerve. Spinal nerve breaks into two: dorsal ramus, ventral ramus. The ventral ramus will become the part that will join to make the brachial plexus. Then if you look at this structure, this one, the dura mater, arachnoid mater, and pia mater are shown in this structure. It's the same like the one that we have dealt with, but it's just showing that there are these meninges. These meninges, they continue to the brain. They continue to cover the central nervous system, spinal cord, and the brain. So when you hear about the patient that is diagnosed with meningitis, what is meningitis? Is the inflammation of these meninges. But you can just leave it there because this is not our topic. So when they speak about meningitis, they speak about the inflammation of these meninges. Now let's have a look on the brachial plexus. Since we say we have 4 different types of plexuses. We have above here the cervical plexus. We will have a separate video to explain the cervical plexuses. Today we are dealing with the brachial plexus. The other day we're going to take the lumbar plexus. The other day we're going to take the sacral plexus. So we said after the dorsal root and ventral root, after they come together, they become the spinal nerve. Then the spinal nerve will separate to become dorsal ramus and ventral ramus. Now that's where we see the beginning of the brachial plexus. Then when you look at the patient, and you look at the patient above the sternum, you can't be able to palpate the brachial plexus, because if you can feel the sternocleidomastoid muscle, that are obvious muscle at the anterolateral surface of the neck, and then you palpate a little bit laterally, then behind the sternocleidomastoid muscle we have 3 muscles that are called scalenes anterior, middle, and posterior. So the brachial plexus is between anterior and middle scalene. So immediately after the scalene, you can be able to palpate the brachial plexus just above the clavicle, lateral to the scalene's muscles. You can palpate the brachial plexus. And then the brachial plexus, they are situated between the clavicle and the first rib. So depression of the clavicle can compress the brachial plexus together with the artery that is situated next to the brachial plexus. So any overcompression of the clavicle can impact the mechanical interface of the brachial plexus. So the brachial plexus is divided into 5 parts. Part number 1 we call the roots. We have 5 roots: C5, C6, C7, C8, and T1. 5 roots that make the roots of the brachial plexus. And then these roots, they will combine and become trunks. We have 3 trunks: superior, middle, and inferior. Then the same 3 trunks will separate into 6 divisions. 6 divisions will combine again to make 3 cords. Then from the cords, they will further divide into terminal branches. I think we will have separate explanation or separate videos to explain each individual nerve, each individual terminal branch in detail. But today we'll just mention what muscle are supplied by these terminal branches. Firstly, let's look at the roots. Root C5 and C6 will come together and join and make the superior trunk. And C7 will remain untouched and become the middle trunk. C8 and T1 will join together to become the inferior trunk. And then another point that you need to take note of, the cervical nerves, the cervical vertebra is 7 vertebra, that is atlas up to C7. Atlas axis C3, C4, C5, C6, C7. But the nerves in between is 8. Is 8 because the first nerve C1 is above atlas, C2 is below. So there is one extra nerve in there when you count the nerve and comparing them to the vertebra of the cervical spine. So we have C1 up to C8, that's why you see C8, but the vertebra, we have 7 vertebra. So the brachial plexus is C5, C6, C7, C8, and T1. They all make the brachial plexus. So now let's look at the roots. What branches are we getting from the root that goes straight to supply muscle? If we look at C5, or before we go to C5, remember I said this short-lived spinal nerve will separate into two, into dorsal ramus and ventral ramus. The ventral ramus is the part that will become the brachial plexus. So, in other words, the root of the brachial plexus is actually the ventral rami of the spinal nerve. Look at it up there. 5 roots of the brachial plexus is actually the ventral rami of the spinal nerve. The dorsal rami will not be part of the brachial plexus. This part is going to supply the muscle right at the back. Now we will get from the roots of the brachial plexus these branches that doesn't have specific name. It just mentioned that these branches, they will supply the longus colli muscle and scalene. Remember I mentioned the scalene. These branches, they will supply the longus colli muscle and scalene. Longus colli muscle is one of the 4 deep neck flexors that are very important. We'll discuss with other time when we do something else, when you deal with those muscles. Right. If you look at C5, there is this branch called the dorsal scapular nerve. The dorsal scapular nerve is a nerve that will supply the muscle that is situated between. This dorsal scapular nerve will supply the rhomboid minor and rhomboid major. Those muscles, they attach at the medial border of the scapula. They help with the retraction of the scapula. That's a dorsal scapular nerve. Is for that. The other branch is to supply subclavius muscle. The other branch is to join the phrenic nerve. The phrenic nerve is actually from the cervical plexus. Actually, the phrenic nerve is supplied by nerve root 2, 3, and 4. So this part is going to join the phrenic nerve. Phrenic nerve is a nerve that will supply the diaphragm. So the function of the diaphragm is completely dependent on the integrity of the phrenic nerve. So any damage to the phrenic nerve will affect our respiration. It's very, very important nerve, the phrenic nerve. So if someone gets a spinal cord injury around C3, C4, the chances of that patient to survive if he's not in ICU, they are very small. Any injury around that area will affect the phrenic nerve. If the phrenic nerve is affected, the patient cannot breathe independently. Therefore, the patient will be intubated and patient will need ventilatory support. So we spoke about the dorsal scapular nerve that supplies the rhomboid minor and rhomboid major. The function of those muscles is the extraction of the scapula, is helping also to stabilize the scapula. We also have the brains that join the phrenic nerve. And the other one that is from root 5, root 6, and root 7, it comes together. This muscle is called the long thoracic nerve. This long thoracic nerve is also very, very important. The long thoracic nerve will supply the serratus anterior. Serratus anterior are the protractor of the scapula. They help with protraction. Serratus anterior. They originate from the ribs, from the anterolateral part of the ribs, and insert on the medial border of the scapula, on the anterior part of the medial border of the scapula. The function is to pull the scapula anteriorly during retraction. It also helps to stabilize the scapula during flexion through elevation or abduction. Is also a big player there. So if you see the winging of the scapula, you need to check the integrity of this nerve, because if this nerve, this long thoracic nerve, is injured, the presentation of that injury will be the winging of the scapula. The palsy of this nerve will affect the scapula. It will display winging, you see. The winging is not always the long thoracic nerve. It can be the long thoracic nerve, or it can be just the weakness of the serratus anterior without the involvement of the long thoracic nerve. Okay, we can continue. Right. Now we said it's 5 roots. Those roots, they combine and become 3 trunks. We have the superior trunk, we have a middle trunk, we have the inferior trunk. From the roots, we have these branches that supplies the longus colli muscle and scalene, and then we have the long thoracic nerve, we have the branch that join the phrenic nerve, we have the dorsal scapular nerve that supply the rhomboid minor and rhomboid major. Right? If you continue to the trunk, we will only see 2 branches that are from the trunk. Right? Only from the superior trunk. The superior trunk has got 2 branches, the suprascapular nerve and the nerve to the subclavius muscle. The suprascapular nerve is the nerve that will supply 2 muscles. Those muscles are called supraspinatus and infraspinatus. Supraspinatus and infraspinatus is part of the rotator cuff muscle, and supraspinatus, they help with abduction of the forearm, especially the early 10 to 15 degrees of abduction is the function of the supraspinatus. And infraspinatus is lateral. It also helps with lateral rotation. And all the 4 rotator cuff muscle, the supraspinatus, infraspinatus, teres minor, and subscapularis, they function to stabilize the head of the humerus during abduction. When deltoid muscle help to abduct the arm, then those 4 muscles will help to pull the head of the humerus within the glenoid cavity, within the glenoid fossa, I mean. Right. For patients with upper motor neuron lesion like stroke, especially the HEMI patients, you will realize that we are just moving a little bit away from this explanation of the brachial plexus just to make it interesting, so that you will know how to, just to trigger your clinical understanding, your clinical reasoning. When the patient have suffered a stroke or any upper motor neuron lesion and present maybe with the HEMI, So which means there is a problem. Let's say the right side is affected. The patient can't use the right upper limb, patient can't use the right lower limb. And then since the shoulder complex is mainly controlled by dynamic stabilizers, that is muscle, that shoulder complex is highly dependent on dynamic stabilizers, rotator cuff, and all other muscles that are involved. So now there is no activation from the central nervous system. Those muscles are not doing their job to keep the head of the humerus within the glenoid cavity. So what will happen? The physiotherapist will have to make sure that that arm is positioned in a right position right at the beginning, because normally after the stroke the patient will present with hypotonia. Flaccidity or hypotonia will be the first sign after the stroke, and then thereafter maybe there will be increased tone, hypertonia. But the main problem that will have is the shoulder pain, because but we can leave it there, because it's a lot of information that we have to deal with. But for you to just to remember that if the shoulder is affected, is because the brachial plexus are not taking the information to the necessary structures that are dynamic stabilizers of the shoulder. So these two muscles, the supraspinatus and infraspinatus, are supplied by the suprascapular nerve. You can palpate the suprascapular nerve on the superior border of the scapula. Is situated in the suprascapular notch, this suprascapular nerve. Its function, it supplies the supraspinatus, infraspinatus, and also the glenohumeral joint capsule. The other branch is supplying the subclavius muscle. Subclavius muscle is muscle that originates from the first rib and insert in the inferior part of the clavicle. And the function of this muscle, subclavius muscle, is to depress the scapula, is to counter the act of the sternocleidomastoid, scalenes, because all those muscles, they pull the clavicle up. Then to counter or to balance that act, the subclavius muscle needs to be activated to keep the clavicle at the right position. So it also helps to depress the clavicle. Okay, we are finished with the trunk. And then I said the trunk will further divide into 6 divisions. And then from these 6 divisions, there is no specific nerves that branches from the 6 divisions. But what you need to take note from the divisions, these 6 divisions are divided into 3 anterior divisions and 3 posterior divisions. And there is a clinical significance for this. You need to understand this. The anterior division will eventually become the nerves that will supply the anterior part of the upper limb. All the anterior muscle of the upper limb, that is forearm and arm, will be supplied by the nerves that branch from the anterior division. And the posterior division will eventually become terminal branches or terminal branches that will supply the posterior part of the arm or posterior part of the upper limb. So these nerves, the posterior division will supply the extensors. The anterior division will mainly supply the flexors. So if you follow it like that, but since this picture is not 3-dimensional, these one are mainly posteriorly, and these are mainly anterior. That's why we have anterior divisions. So from the divisions, we don't have we don't have branches that will supply muscles. Right, let's continue to the third part, to the fourth part of the brachial plexus. The fourth part is 3 cords. 2 division will come together and make lateral cord. 3 division will come together and make posterior cord. And that 1 division will continue to become a medial cord. Remember, all the posterior divisions, they all come together to make the posterior cord, which means is that part that will supply the posterior part of the upper limb. Right, before we follow them to the terminal branches, let's have a look and see what branches we get from the cords, because it's a number of them that we get from the cords. But we'll try to explain it so that you understand it. Right, it is advisable before you try to follow this video of the brachial plexus, at least to be up to date with the knowledge of your muscles, because these nerves, they will eventually supply muscles. Right, from the three cords we have 7 terminal branches. They are easy. We'll try to simplify them. We mentioned the one from the roots. We mentioned the ones from the trunks. We said there is nothing from the divisions. Now from the cords, it's 7 terminal branches that will supply muscle directly from the cords. Right, we have these. Let's take from the posterior cord first, because these 3 nerves are similarly from the posterior cord. Right, that is lateral cord, that is medial cord, and that is posterior cord. Right, when we look at this posterior cord, there are 3 nerves coming from the posterior cord, and they have a similar name. They are not that difficult. Right, where these 3 nerves are called subscapular nerve, because they go under the scapula. Therefore, they are called subscapular nerve. Right, this one is upper, this one is middle, this one is lower. So this is upper subscapular nerve, this is middle subscapular nerve, this is lower subscapular nerve. The upper subscapular nerve supplies the subscapular muscle. Subscapular muscle is part of the rotator cuff muscle. Since we said it's 4 rotator cuff: supraspinatus, infraspinatus, teres minor, and subscapularis. Subscapularis, the muscle that is situated, that originates